All right, so in this video we're going to be going over pharmacology, how to administer a drug, the indications, the contraindications of these different drugs. So we're going to go through about 8 or 9 different drugs. We're going to talk through it, and some of the ones that require a little bit different administration or technique to administer it, I'll show you that as well. So we're going to start with aspirin. Aspirin is for our chest pain patients. Aspirin is a platelet inhibitor, so a lot of people think that aspirin actually thins the blood, and it actually doesn't do that at all. It makes your platelets slippery, so if you've got chest pain and you've got atherosclerosis building up in those arteries and everything else, you've already got some blockage, and this will help lubricate those red blood cells to either pass through or not clump together and create further blockage. So the indication for this is chest pain. Contraindications to this is a history of asthma, bleeding stomach ulcers, or any sort of hypersensitivity to the drug. Obviously, when you're doing this, you want to look at the date, make sure that everything's intact, make sure that it's not expired. And to administer, we give a dose of 4 81 milligram tablets of chewable aspirin. So you can pour 4 tablets into the cap and have the patient retrieve them. If the patient is not able to retrieve those tablets, then you can assist them and put them in their mouth. If you have a patient that has already taken a daily aspirin, a lot of people are on an 81 milligram daily aspirin regimen. You can give 3 if you'd like to. 4 is still fine. Studies have shown that people that are on a daily aspirin regimen actually have enough aspirin in their system at 81 milligrams. So the extra dosage is really kind of a moot point. But our protocol does say give up to 4 81 milligram baby aspirins for chest pain. All right, continuing down the path of chest pain protocols and drugs, we'll talk about nitro. So nitro comes in 2 different forms. You've got a metered dose spray, and you've got nitro tablets. Both of these are demo drugs. This is just packaged how nitro would come in the spray bottle or the tablets. Be very careful when you're handling nitro, especially the tabs. If you're not wearing gloves, it can actually soak and absorb into your skin and give you some of the same effects that it would give the patient. So if you're going to handle the nitro tabs, make sure you've got your BSI on. The nitro spray, be careful where you spray that. A lot of people find it common to prime the pump, so to speak. So if they haven't used it for a while, or they aren't sure if they used it for a while, or if it has been used by another crew or not, they'll give a test spray just to make sure that it's primed, that they're not giving the patient a half dose or no dose or whatever else. Be careful when you spray this, especially if it's in dead of winter or the dead of summer where the AC or the heat is blowing continuously. This becomes very aerosolized, and it has a tendency to get sucked up in the air system and circulate around the back of the ambulance, or if you're in a closed spot, you could start feeling some of those effects as well. So the dose of this is 0.4 milligrams. It doesn't matter which one you use, whether it's the spray or the tabs. Contraindications for this: any patient that has recent ingestion within the last 48 to 72 hours of any sort of erectile dysfunction drug, Levitra, Cialis, Viagra, any of those. One thing to be cautious of is those ED drugs, so to speak, are not just male drugs anymore. Women take them for various reasons, so don't just assume that because your patient is a woman that they don't take any of those drugs. So always ask. Sometimes they'll admit to it, sometimes they won't, but make sure if you suspect that they may be of the age that they may take it or anything like that, or you've got some indication that they do take it, try to get that information out of them. You can always say something to like, if you take any other drugs that I don't know about and I give you this, it can completely bottom out your blood pressure. Sometimes that'll get them to talk. So they have to have a systolic blood pressure of at least 90 in order for us to give this. You can give it up to 3 times, 5 minutes apart, as long as the systolic blood pressure stays above 90. Otherwise, the only real contraindication is not having chest pain, of course, and recent ingestion within the last 48 to 72 hours of erectile dysfunction type drugs. For the spray, you'll indicate to the patient that they need to open their mouth, raise their tongue to the roof of their mouth, and you'll spray this sublingually. So you'll spray it underneath the tongue, in between the bottom teeth and the base of the tongue where you can see. Just insert it and spray. For the nitro tabs, administration is the same, but instead of spraying it, you pour one out into the cap or your glove. Again, these aren't real. These are just plastic tablets, but you can see them in the cap there. And you'll administer one under the tongue and just advise the patient that they need to wait for it to dissolve. Side effects with this, nitro is a vasodilator, so it's very common for them to experience an excruciating headache after we give this. The goal is to expand those cardiac vessels to reduce the amount of work that the heart's doing to pump. And when we do that, we're making the container bigger with the same amount of volume, so it has the tendency to drop their pressure, which of course could cause the headache. So vasodilator, 0.4 milligrams per dose. You can repeat the dose up to 2 additional times for a total of 3 sprays or 3 tabs, and their systolic has to remain above 90 millimeters. All right, so let's talk about oral glucose. Oral glucose comes in a tube similar to this, and it comes in a variety of different flavors. None of them taste good, but they make pina colada, strawberry, grape, lime. This one happens to be lemon. So the dose is going to be 25 grams. Remember that we're not giving this all at once, and this is for diabetic emergencies. Patients still have to have an intact gag reflex, and generally speaking, you don't want them to be altered. However, in a diabetic emergency, most people are going to be altered. So that's not necessarily defining of whether or not you can give this. If they're altered and confused but can still swallow, they can still maintain their own airway, you're not worried about any sort of choking or aspiration hazard, you can still give this. So again, the dose is 25 grams. Just don't give it all at once. We're going to give this the buccal route, so it's going to be in between the cheek and the gum line. You just want to screw off the tip and just inject a little bit at a time. Allow that to dissolve. Once that dissolves, go ahead and administer just a little bit more, wait for that to dissolve, and so on until you get a change in mental status with your patient, or ALS arrives on scene and can give intravenous sugar to the patient. No real contraindications to this other than the fact that they have to be able to swallow, they have to be able to maintain their own airway, and an intact gag reflex. Otherwise, if they're experiencing a diabetic problem, hypoglycemia, remember low blood sugar, then you can administer this as long as all those things are in place. Going along with diabetic emergencies and things like that, I'm going to go over Glucagon with you guys. Glucagon comes packaged in a box similar to this. This is an expired medication that I'm going to use. So for our protocols, EMT Basics can give Glucagon one of 2 ways now. It used to only be intranasal administration, but now we allow EMT Basics to give Glucagon via the IM route. So your dosage is going to be different between the 2 routes. If you're going to give it IN, okay, through the nose, it's going to be 1 milligram in 1 ml per nostril. Okay, so this is packaged 1 milligram per milliliter. You'll need 2 boxes in order to administer it IN. Now to administer it IM, intramuscular, you only need 1 box. The total dose is 1 milligram in 1 ml. So it's up to you however you administer it. You can do it either way. So I'm going to use just 1 package, and I'm going to show you how to draw it up, how to mix it, and then how to administer it. So the package comes like this. You've got 1 vial that's a powdery disc-like substance, that's the glucagon, and you've got 1 vial that is just saline. And you see that they each have a cap on it, 1 orange cap and 1 white cap. So the white cap is going to be our saline, and the orange cap is going to be our disc. You can kind of see the medicated powder in there. So you're going to want to pop the caps off. You can just use your thumb to pop the caps off like this. And you're going to take the vial that has the saline in it, and you're going to draw up the saline and then you're going to end up injecting it into the vial that has the disc in it. So when you draw anything out of a vial, you want to make sure first that you inject air equal to the amount of volume that you're taking out. So we know that this is 1 milliliter or cc of fluid. It tells us right on the vial. So I want to pull back on the syringe, and I'm going to inject 1 milliliter or 1 cc of air into the vial. If I don't do that, it kind of creates a negative pressure, and it's going to fight me when I go to draw the complete amount of the medication. Okay, so you can see in here, the syringe is actually starting to just backfill itself just because of the air pressure that I've already injected. I'm going to back this out just a little bit. You want to have your needle as close to the rubber gasket on the bottom as you can, or else it's going to become difficult to get the rest of the fluid out. Sometimes you have to work just a little bit back and forth to get all of the fluid out. Okay, so it appears that I've got all the fluid out, so I'm going to go and take the vial off of the needle. I'm going to lift or push the plunger back up into place to 1 milliliter. See, I've got just a little bit extra in there. Get the air out, push that back up. I'm going to give it a good couple flicks to make sure that there's no air bubbles in there. So you can see that I've got 1 milliliter of solution. And also here you want to make sure that it's the tip of the plunger that's at 1 milliliter. So now I'm going to inject the milliliter of saline into the actual glucagon powder mix. In this case, I don't need to inject air. Okay, that's injected. I'm going to put my needle aside. And you see here that it is already fairly dissolved. Now the important thing with this is we want to reduce the amount of air bubbles that we create. So you don't want to shake glucagon when you're mixing it. You just want to roll it in your hands. So roll it back and forth. Mix it up. You are going to have a few air bubbles, but far less than what you would have if you actually tried to shake it. Okay, so you can see that it's pretty well mixed. There's very few bubbles in there, just a little bit of a frothy foam on the surface. So now I'm ready to draw it back out. So I still have 1 milliliter in 1 milligram of solution here. So I'm going to follow the same directions, and I'm going to inject 1 milliliter of air into the vial. And then I'm going to draw the medication out, and now it's mixed. Draw back the full dose. I've got it all in. And I'm going to move my stopper up to 1 cc. You can see there that I've got it drawn up. And so I'm ready to inject this intramuscularly. If I chose to do this intranasally, I would have 2 milligrams in here, and I would switch this out with a MAD device. But in this particular case, I'm ready to give it IM. All right, so now let's move on to albuterol sulfate. I'm not going to actually talk about the administration of it because I cover that in the nebulizer video, but I'm going to talk about the packaging, the dosage, and things like that. So albuterol is for asthma. It can be used also in COPD for patients that are having COPD as well. So you're really looking for shortness of breath accompanied with wheezing. And the dosage of this is 2.5 milligrams in 3 milliliters of solution. We're not measuring it out. It's already pre-filled, and I'll show you that here in just a second. This is how it comes packaged, your albuterol sulfate. We can open it up here. Comes in a clear tube, okay, like this. And all we're going to do to administer it is twist the cap off. Okay, you can discard the cap, and then you're going to end up injecting this, turn it upside down, and squeezing the vial into the reservoir for the nebulizer. No real contraindications in the pre-hospital setting. Again, asthma, COPD. You may see people get a little bit tachycardic, a little bit anxious, a little bit jittery after the administration of this because it's a bronchodilator. It's helping to open up that airway and keep the alveoli open, almost like a little bit of a splint to try to keep those grape-like structures open so that they can breathe a little bit better. All right, so moving on, we're going to talk about Narcan. Narcan comes packaged like this. It's in a peach-colored like package. Naloxone is what it's called. We call it Narcan for short. These come packaged 1 milligram per ml, and there's 2 milliliters or 2 milligrams in the packaging here. So that is up to your full dose. Easy open tab. Right here just says open here. So go ahead and stick your thumb through that, peel it back. So when you open it up, you're going to find the actual vial with the Narcan in it, and you're going to find the syringe-like adapter to be able to administer it. So on here, anything yellow comes off, and on here, the red cap comes off. So we're going to unscrew the tip here. It's got a lure lock design, so it's going to adapt onto any IV tubing or anything that accepts the lure lock. So the MAD device, for instance, if you're administering it intranasally, which we'll be doing. The back here has a yellow cap. Really, you shouldn't get poked by this, but do be careful when you flick it off not to stick your thumb in there because there is a needle right there at the end. It doesn't protrude past the end, but if you stuck your pinky in there or something like that, you could easily get pricked by that needle. And then the red cap here, same thing, just pop it right off. So in order to assemble it, all you're going to do is meet the two ends together, and you're going to screw it into place. Okay, we're all set to go. So now we have the Narcan, 2 milligrams and 2 mLs, and we've got the syringe to be able to administer it. We're going to administer this with a MAD device. So we're going to screw that onto the tip of this. Now we're ready to administer. So with this, you want to make sure that you're not pushing too fast but not too slow. You just want a small, good steady stream. You can kind of see here that it's a good stream, and that's what we're looking for. So we're using this for drug overdoses, specifically narcotic drug overdoses and opioids, so things like your heroin, stuff like that. Remember, when we give this, we don't necessarily care about the patient being unconscious or unresponsive. That's okay. We're giving this to reduce their respiratory distress or respiratory arrest due to their opioid overdose. So if they're breathing less than 8 times a minute, consider using the Narcan to a point where we've restored their respirations. But again, we're not looking to restore their level of consciousness. In most cases, it's better for us that they're unconscious. They have a history of wanting to fight. They have a history of projectile vomiting. And if you give enough Narcan, it actually reduces the ability for the body to constipate, so they can have explosive diarrhea as well. So narcotic overdoses where they have respiratory compromise. The dose of this is going to be up to the full 2 milligrams. We like to do what's called titrate to effect. So you might give a half a milligram at a time in each nostril, or just a half a milligram, wait a minute or so, see if they have any sort of respiratory improvement. If not, you may try another half a milligram, and you'll work your way up to the 2 milligrams to see where your patient ends up at. Otherwise, no in-the-field emergency contraindications. If they happen to be overdosing on something that's not an opioid or narcotic, this won't work. And if it happens to be an unconscious person where you're really not sure whether they overdosed or not, it's not going to be harmful for them. It just may not work. All right, so now I'm going to cover EpiPens with you. I've got the EpiPen Junior, which is for pediatrics. I've got the regular EpiPen for adults, and I've got a different style, kind of an off-brand epinephrine auto-injector. It's not the name brand EpiPen. The reason I want to show you the difference between the two of them is there's a little bit of a difference and fairly significant potential safety concern when administering the two. So the off-brand, the one that's just the epinephrine auto-injector, has a 2-stage system in order to administer it. It does give you directions on the pen to administer it. But the first thing you're going to do is pull this end cap. Okay, that's your safety cap. And then the next thing you're going to do is pull this, which actually engages the spring and the mechanism to be able to administer it. Okay, so this is now live, ready to be injected. I've got an IM injection pad here that we're going to inject it into, and I'll show you the safety concern at the end. It's really just something that you need to be aware of, especially if you're not familiar with these. Alright, so with the epi, we're giving this for an allergic reaction, specifically an anaphylactic reaction where they've come in contact with some sort of food, some sort of insect, something that's causing their airway to close off. Typically you're going to see hives, redness, they may have itchiness, they may have a hoarse voice, you may see swelling, you may see angioedema on the lips, the tongue, they may say that it feels like they've got a lump in their throat. So that's what we're looking for. This is administered on the outer thigh, doesn't matter which leg. If you have time to expose the direct skin and sterilize it, clean it up with an aseptic technique such as alcohol swab or something like that, then go ahead and do that. If you don't, it's fine to just inject it right through the clothes. So you want to prepare your patient, let them know what you're doing, especially if they're conscious. This is going to hurt. We're jabbing a needle into their leg for about 10 seconds. So let them know what's going on. I've got my IM injection pad here. Also a note on this, don't put your fingers over any of the ends, okay, like this. The needle only comes out of this end, or in the case of these other ones, okay, the orange tip. But in the heat of the moment, we may forget which end we've got. We may be in such a rush to administer the epinephrine that we accidentally put our thumb over the wrong end. We engage the needle, and now we've got an EpiPen, and we've administered ourselves a dose of epinephrine. So hold it like a fist and just inject it that way. That way you've got no fingers that are exposed. So I'm going to go ahead and inject it. Remember, inject it into the outer thigh, and we're going to hold it for 10 seconds to allow the medication administration to fully inject and absorb into the muscle. Alright, so you'll see here that after I've taken it out of the injection pad, you can see that the needle is still exposed. Okay, this does not have a self-retracting needle. So be careful when you administer this that you recognize that this is not something that self-retracts and you just toss it to the side and then say, hey, I'll put it in the sharps later or something like that. Now, this system does have a design that you're supposed to insert back in. There's a thick foam pad on the bottom of this that absorbs the point of the needle, and then you just recap it. So this whole system will go into your sharps container. So with the traditional EpiPen or the EpiPen brand, you only have one safety device. You've got the blue safety device at the end. Take that out, and your EpiPen is now live. Your adult dose of Epi is going to be 0.3 milligrams, and if you're administering Epi Junior, it's going to be 0.15 milligrams. They're both administered the same. Obviously, this one for kids, half the dose, this one for adults. So I've got my injection pad, same rules apply. Okay. Again, don't put anything over the ends. Administer, hold for 10 seconds. Okay. And as I retract, you see that the orange tip comes out and it envelops the end of the needle. Okay, so there's nothing to get stuck with. And no matter how hard I try, okay, this won't come back down. So this itself can just go into the sharps, and the plastic housing that it came in, you can just dispose of however you want. Some people do still put them back in the sharps, or the container. It obviously doesn't fit, but you can just dispose of the whole thing in the container.